Hello, this is Dr. Bhomik. Today I'm going to present a couple of interesting cases, and this case is not very well known to the pediatrician, but pediatric endocrinologist have dealt with this kind of case, but it is indeed rare. We do know that hypothyroidism like Hashimoto's thyroiditis is very common, but occasionally there is some sequela of Hashimoto's thyroiditis, and that's what I am going to describe these two patients. These two patients admitted in our PICU, and we actually presented this case in University of Alabama, Birmingham Regional Pediatric Society meeting in October 2013, and there was two cases that we presented, and I thought that this will be a good educational process for the pediatrician, pediatric endocrinologist, as well as the pediatric fellows. And this case has been reported in the literature also off and on, and from that point I will also put some of the literature information at the end of my presentation. So again, this patient was managed. One was by me and another was my partner, who is Anne-Marie Koffers. At that time she was associate professor, and we both had one case each. So let's try to just introduce the subject a little bit. We all know that Hashimoto thyroiditis is the most common cause of acute hypothyroidism, not only in pediatrics but definitely in adult and also in pediatrics. And to make the diagnosis, one has to show the microsomal antibody or thyroid peroxidase antibody, anti-thyroglobulin antibody in the serum of the patient. Now, anti-microsomal or what called thyroid peroxidase antibody is more specific, and sometimes autoimmune thyroiditis or Hashimoto's thyroiditis may be associated with type 1 diabetes, additional disease, and other autoimmune endocrine condition. But Hashimoto's encephalopathy is rarely been reported in children and adolescents, and most of the time if it is reported, it's mostly in the form of case report. So my goal and objective is to present two cases, one male, one female, and discuss the various neuropsychological symptoms and the clinical manifestation of this condition. And we'll also try to elaborate the accepted criteria to make the diagnosis of Hashimoto's encephalopathy. And we will talk about the differential diagnosis and the therapy of encephalopathy, as well as a brief literature review. Patient 1 was actually my patient, and this was a 9-year-old Caucasian male who has a history of severe headache off and on, and also history of migraine headache, and the migraine headache was bad enough to be diagnosed as a hemiplegic migraine by the pediatric neurologist. So the diagnosis of hemiplegic migraine about 1 year ago, and he presented to the emergency room with the acute onset of right-sided hemiplegia and he cannot talk. He stopped talking. He has aphasia. In emergency room, he developed generalized tonic-clonic seizure, and family history is negative for any seizure disorder or thyroid disorder, and this patient was not diagnosed with any thyroid condition before. So has a low-grade fever up to 100 degree Fahrenheit, and weight is 75th percentile and height on 50th percentile. Normal, no dysmorphic features, and his seizure was so intractable that we end up in intubating. A neurologic consult obviously was made, and patient was in PICU, and further management will be discussed as we go along. Thyroid studies, I have put it in the table, and we show the evidence of Hashimoto's thyroiditis. We did the CSF study, and there was no pleocytosis, however significant, elevated in protein. It was 142 milligram per DL, and the normal value is in parentheses. We did the EEG, which was abnormal and is raised at intermittent slowing over right parieto-occipital region. MRI shows hyperintense signal along the gyri and sulci, and post-contrast study showed diffuse leptomeningeal enhancement both sides bilaterally. Patient 2 was a Dr. Coffer's patient, and this was 13.5 years old female, Caucasian female, also presented to the emergency room with generalized seizure. This patient has problem, different kind of neuropsychiatric symptoms for a long time, diagnosed with ADHD on 4th grade and was on medication for that. And he had a history of frequent episode of memory loss. He wouldn't even remember what he ate and what he did, and when mom tried to emphasize that she's forgetting the stuff and also not remembering, she tend to get very irritated, confused, and hesitated. And mother says that she has been mostly to herself and depressed. Secondary sexual development is appropriate for the age. She started her period about 12 years of age. And about 4 months ago, she was diagnosed with hypothyroidism in pediatrician's office, but we did not have any information of the thyroid function, but she was on levothyroxine. And thyroid studies again is in the table and shows clearly she also has Hashimoto's thyroiditis. Like the first patient, she has no pleocytosis, significant elevated protein with normal glucose, and EEG shows the diffuse encephalopathy with diffuse burst and slowing occurring intermittently. In addition to thyroid antibodies, interestingly, she also has GAD, glutamic acid decarboxylase, ANA, and anti-adrenal antibody. So there is quite a few autoimmune process was going on. And the family history is interesting for the mother and older sister who was diagnosed with seizure disorder, and also has thyroid problem, Hashimoto's thyroiditis around teen years of age, and has been on thyroxine. Maternal grandfather had bipolar disorder and schizophrenia. Paternal grandfather died of Lou Gehrig's disease. This patient was admitted to PICU as well, but did not require intubation. Again, thyroid studies will be coming in the table. GAD was positive, more than 250, as I said before. CSF protein was high, 83, with normal glucose. The MRI show acute changes and left arachnoid cyst, but that was on the left side of the cerebellum, and that probably was incidental finding. EEG shown no epileptiform discharge, and suppression type of EEG lasting only for a few seconds at variable intervals. So it was not as pronounced changes as we saw in the first patient. So here we are. This is the first patient, patient 1, and with hemiplegia, aphasia, seizure, and free T4 was 0.28, which is low, and TSH was 60.13, which is significantly elevated. Thyroid peroxidase antibody is significantly high, 3340.5, and so as the thyroglobulin antibody, which is also significantly high. Patient 2, thyroid free T4 is low normal, TSH is still a bit elevated, but has significant thyroid peroxidase and anti-thyroglobulin antibody. So in hospital, both patients was started on a rather large dose of methylprednisolone IV, and that was given for 5 days and followed by the oral prednisone. Both of them also received IV immunoglobulin, and significant improvement noted in about 48 hours. And finally, patient was sent home after when the seizure and patient condition improved and seizure abated, and was sent home on oral prednisone with a tapering dose. Now, how one can make a diagnosis of Hashimoto's encephalopathy? The diagnostic area of Hashimoto's encephalopathy has been proposed by American Neurology, Psychiatric, Endocrine Association. There is a combined agreement, but still a lot of people don't agree with these statements. But this is what the best I could find. So diagnostic area include a seizure, stroke-like event, focal neurological deficit, and another thing that elevated thyroid antibodies, especially the antimicrosomal antibody or TPO, thyroid peroxidase antibody, has to be there. With the patient could be hypothyroid or even euthyroid. And patient also should show the significant response with corticosteroid therapy. CSF uniformly should show elevated protein but no pleocytosis. There should not be changes in the glucose as well. EEG might show the mild to moderate generalized slowing, and MRI is again a non-specific changes has been noted, but nothing is written to be most characteristic finding of Hashimoto's encephalopathy. So it is a non-specific finding as far as MRI is concerned. So differential diagnosis, obviously any encephalopathy. Hashimoto's encephalopathy is the rarest cause, so therefore other infectious cause, metabolic cause, toxic cause, any vascular or neoplastic cause of encephalopathy must be excluded with appropriate investigation. So those are the things has to be evaluated and should be ruled out. Even this patient is known to have hypothyroidism. So again, those things should not be ignored. The most important differential diagnosis is Jacobi-Creutzfeldt disease, which actually occurred mostly when our kids were receiving the cadaveric or pituitary extract of the growth hormone. And actually this disease is the one which stopped the growth hormone for a while until we got the synthetic growth hormone. So this we don't see very well. However, this is a little bit historical fact that this kind of disease was also prevalent a lot in a place called Papua New Guinea, where the tribes used to kill each other, and one of the part of the ceremony they eat their brain, the brain of the enemy. And so that disease used to be known as Kuru, K-U-R-U, Kuru, and which is the very identical with Jacobi-Creutzfeldt disease. And early Alzheimer's disease may behave same way. So these differential diagnoses should be excluded. And again, the treatment is very high dose of methylprednisolone, and its dose is determined by mostly the neurologist. And in our patient, it was 0.5 to 1 gram. We gave like IV 3 to 7 days, and it followed by the oral prednisone, 1 to 2 milligram per kg. Try not to exceed more than 60 milligram per day. For about 6 to 8 weeks. Then slowly and gradually the steroid dose was tapered over the period of 6 months or so. We make sure that thyroid hormone replacement has been adequate. And IV gamma globulin was given for 5 days, and the booster dose was given after 4 weeks for about 4 to 6 months. And then when there is a recurrence, then we had to use IV gamma globulin also. In occasionally, literature says that they have used the plasmapheresis, but that was not necessary in our patient. So recurrence do occur, and quite a few patients will show the recurrence. And the patient who show the recurrence in the beginning, and they tend to have more recurrence, but the patient who has got a long period of time else between the disease process and recurrence, and they seem to do better. So if the recurrence occurs, then same steroid and IVIG. But if the recurrence becomes a common problem, then chemotherapeutic agent like azathioprine, cyclophosphamide, or methotrexate has been used. We fortunately did not have to use any of those to any of our patients. Periodic IVIG and plasma exchange transfusion has also been reported in the literature, the cases where the recurrence has become a problem. And it is actually rather common. It is rather common. Now, let's go back to the history and prevalence a little bit. This is interesting to see that Brian and his colleague was first reported a case of Hashimoto's encephalopathy in 1966. However, from that point onward, for 1990, there was 8 case report. 1990 to 2000, there is a 43 case report. 2006 is 200 case report, suggesting this condition is rare, however is not as rare, is underdiagnosed as in the past, because people were not aware of that and was not looking for it. And so this is interesting. So in adult literature is very well known, and for pediatric literature, the pediatrician are still probably not well versed about the existence of this condition. There is an estimated adult incidence is 2.1 per 100,000, and mean age is around 40s, mid 40s. And it is again, as with any other thyroid disease, 4 to 1 prevalence in male to female. So more females are affected by this condition than the male because thyroid condition is also more prevalent in female, especially autoimmune thyroiditis. And about 1/5 of the cases appear to be under 18, and 20% of them actually present with status epilepticus, like our first patient. So, how do we define then Hashimoto's encephalopathy? It is defined as a syndrome of cerebral symptoms. And syndrome of cerebral symptoms, as I have already discussed, from the seizure to forgetfulness, aphasia, all other area that has been delineated. But serological evidence should be positive for high Hashimoto's thyroiditis. If the serological evidence like thyroid peroxidase antibodies are not there, then the diagnosis becomes difficult. It is hard to make that diagnosis. However, the one thing has been noted, especially in adult literature, the antibody titer does not correlate with the severity of the condition and the presenting symptoms of the condition. So, positive antibody is there, but the low titer positive could have a worse possible presentation and high titer may not. And thyroid function may vary. Some of them will be hypothyroid and some may be euthyroid, especially if they are on levothyroxine. And there is a case report where the patient was hyperthyroid. That probably represent the toxic phase of Hashimoto's thyroiditis. So the etiology of this condition is not completely understood, and so the pathophysiology still remains speculative. However, autoimmune process plays a major role that people agrees with that, and possibly what we think is the autoimmune cerebral vasculitis may be a significant contributing factor, but the recent literature favors an inflammatory response to anti-neural antibodies. So I think that will probably more possible cause is the inflammatory response to anti-neural antibodies. So this is how we try to divide the presentation of Hashimoto encephalopathy. And but they are so heterogeneous in both types, it's very hard to point finger on one versus another. So vasculitis type, they usually acute onset, acute stroke-like episode with focal neurological sign and seizure. And actually both of our patients presented with vasculitis type, we think, from this definition. However, diffuse progressive type is of insidious onset, and the impairment of the mental condition, confusion, psychosis, seizure, dementia develop over the period of times, and there may be overlap of the symptoms, and easy MRI and CSF study cannot differentiate between diffuse progressive type versus vasculitis. So although there is a definition, but sometimes they overlap each other, it's very hard to make a diagnosis, clear-cut diagnosis, one type versus other. But in all patients are showing the EEG shows the diffuse slowing background, and CT and MRI may be normal, but is commonly observed abnormalities include the cerebral atrophy, diffuse white matter, and the focal mesotemporal abnormalities. Evaluation of positive thyroid antibody in the blood and CSF protein has not been very successful, but protein is elevated, thyroid antibody is detected sometime in CSF, but this is not given all the time. So follow up our patient. Our patients are followed up every monthly for a while, then every 4 to 6 months. And they did show the intermittent remission and exacerbation of symptoms, especially when we tried to decrease the dose of steroid. And both of them required some admission in the hospital for IV gamma globulin. And later on, we managed to give the gamma globulin IV as an outpatient basis. And thyroid function, however, has remained normal on the replacement dose. And we did increase the prednisone dose higher, increase the higher dose to prednisone when there is exacerbation. And patient 2 actually developed type 1 diabetes after 6 months and had GAD positive antibody, and with all that high steroid, it was just was going to happen. And so since my presentation of this case in UAB, my partner had one more case of Hashimoto's encephalopathy, and that was published in American Endocrine Journal, AACE, as case report, and there is a 3 case report, and I will put those reference to the in the information section of my YouTube presentation. And the high index of suspicion is necessary. So if a patient has Hashimoto's thyroiditis and they suddenly develop any neurological symptoms, especially seizure or any neurodeficit, one need to think about Hashimoto's encephalopathy. So hopefully this kind of information made available to the pediatrician will help the people to think. And if you have no high index of suspicion, one is going to miss this case and may not be diagnosed for a long time. So I thought that these 2 cases will help my colleague and medical student or the physician who takes care of the pediatric patient or even adult patient that Hashimoto's encephalopathy exists, and its incident is probably more than we realize, since we do not pay much attention. In the beginning, we did not. I would say that in the beginning we did not pay much attention. So thank you very much. And obviously I am retired, but Dr. Coffers is still in University of South Alabama, and she is now professor of pediatrics and chief in the endocrine division, and she found one more case at the end, and that has been published in American Clinical Endocrine Journal, and I will put that link. Thank you very much.